Hi, I'm Dr. Henry Black. I'm a clinical professor of internal medicine at the New York University School of Medicine and president of the American Society of Hypertension. When a new diagnostic test comes by, our general approach is enthusiasm. This is really going to help us. This is going to be better than our physical exam or our history, and it's really going to help us focus our care on the people who need it. This should reduce hospitalizations, unnecessary ones, and guide treatment so we get better outcomes. One of the most important new diagnostic tests for heart failure is a B-type natriuretic peptide. Easy to measure. You can have it in 20 minutes, sometimes a little longer. But does it really change outcomes? Does it really improve diagnosis? Does it really make a difference? Well, this has been studied in 2 large university hospitals in Australia, where they randomized the measurement of BNP, where everybody got it, but they didn't tell the patients they had it, and they didn't necessarily tell the doctors either. Everybody who came in with shortness of breath acutely to the emergency department had this measured, and then they followed the outcomes. Now, the physical exams would have suggested that it wasn't difficult to tell the people who had chronic obstructive pulmonary disease. They were more likely to wheeze. They were more likely to have had asthma in the past. They were more likely to be smokers. And the people who had heart failure, who had very many of the same complaints and physical findings, that those who ended up with heart failure had a little more edema, but both groups had RALs. And the clinical exam was helpful, but overlapped between the 2 groups. Now, generally, if the BNP is less than 100 nanograms per liter, you don't worry about it. It's not heart failure. And if it's above 500, you do. So that seems to be a very helpful tool, because you would direct treatment toward heart failure, if that's what you saw, or towards something else, like chronic obstructive pulmonary disease with respiratory failure, to the patients who had that, and it wasn't heart failure. Well, this was all done, and it was quite a well-done study, in my opinion. But hospitalization rates were the same, about 85% of both groups. Length of stay was about the same, a little over 4 days for both groups. And outcomes were about the same. People with heart failure had about a 6% mortality. People with respiratory distress that looked like heart failure that wasn't had about a 6.9% mortality, and these were not significantly different. So whereas this is a valuable test to make a diagnosis, it doesn't seem to affect how people do. It may affect how people get treated if we knew right away, but in the end it didn't matter. And the unfortunate thing, I think, is that there was overlap in the tests as well. There were some people who didn't have heart failure, and these were judged by two clinicians, one of whom was a cardiologist who read the data and assigned them to heart failure or not, and the third one broke the tie if they didn't agree. And we can be pretty sure that they had ascertained things correctly, and this was what it was. So there were some people without heart failure who had very high BNPs, and some people who ended up having heart failure on clinical grounds who didn't have high BNPs. So like I think everything else, we've got to temper our enthusiasm a little bit. We can expect that it's only partially predictive, that a negative and positive predictive value, which wasn't calculated here, may not be that helpful. But in any case, I think this is an inexpensive, easy test to do, and something we ought to do more of, but we can't hang our hats on it. Thank you very much for your attention.